Martin, welcome.
Hi, Doctor.
So, Martin, you have keratoconus.
Okay, so how do you treat that?
Well, we're just going to give you some glasses.
Okay, and setting?
No, if it gets worse, we might give you a contact lens.
Okay, so that's it.
Well, if it gets worse than that, we're going to cut the front of your eye off and stick a dead person's eye in the
No
hole.
way. That's crazy.
There's heaps of stitches.
No.
You'll be on drops for life. Your eye's never as strong. Traditionally, keratoconus has lacked intermediate treatment options. Contact lens intolerant patients fall into a grey zone of treatment with the spectre of an invasive transplant procedure looming. In the last decade, however, the options for management have expanded rapidly. Concurrently, collagen cross-linking has emerged as an effective stabiliser of the disease. Once simple guidelines for management are now more complex and far more dependent on each corneal surgeon's particular expertise and access to technology. The most comprehensive guidelines to date were delivered by an expert panel and published in Corneal in 2015. This is still in evolution as developments continue to occur. The two prominent techniques offered by most surgeons to contact lens-intolerant cones are ring implants and variations on PRK. But each requires a nomogram for planning, and neither is a standardised intervention, with large variability in application between surgeons. PRK techniques vary widely, with differences in techniques of epithelial removal, topographic and non-topographic planning, amounts of refraction, targeted and even post-op care. Different laser platforms measure topography by different means and calculate tissue removal with different software. Some are OCT guided, some Schleimpflug and Placido guided. Mitomycin is used for variable times or not used at all. We would contribute to this discussion our experience with topography-guided PRK and simultaneous collagen cross-linking for keratoconus. With FDA approval of topography-guided platforms now available for standard Lasik treatments and collagen cross-linking under consideration, a discussion of this topic is timely. This work was pioneered by Dr. David Lin and Dr. Simon Holland in Pacific Laser Eye Centre in Vancouver, Canada, and encouraged by similar positive results from other centres. Results are now obtained with a mature nomogram developed over 10 years across 3 laser platforms. I was exposed to this as a Corneal Fellow, Vancouver being a great place to learn about challenging topography, best fit spheres, and poorly fitting ski jackets. The technique is topography guided, trans-epithelial, and incorporates a refractive treatment. Mild myopia is targeted in anticipation of flattening, with collagen cross-linking performed simultaneously. Cross-linking is performed with a 10-minute induction and a 9 mW per centimetre squared irradiance. Mitomycin C is applied post-procedure for 30 to 50 seconds. Across different laser platforms, the principle of cone regularisation is similar: a partial myopic ablation to flatten the cone, and a partial hyperopic ablation to centralise the apex of the cornea. Since returning to Sydney Eye Hospital, this work has continued in collaboration with both Vancouver and Switzerland. The following are representative cases from our Sydney cohort with minimum 12-month follow-up. All were contact lens intolerant cones considering transplant or ring segment implantation. Of 22 eyes treated, the mean Kmax was 52.7, with a range of 49 to 67. Average tissue ablated was 98 micrometers with an average thinnest point of 380 micrometers and a range of 310 to 450. Three patients within the cohort had significant relief from headache post-treatment. These tended to be cases with high asymmetry between eyes. One patient ceased contact with a neurologist who was treating this problem pharmacologically. One case within the cohort was post-LASIK ectasia referred for corneal transplantation, with functional vision salvaged by the laser procedure. One case was referred with documented progression and early keratoconus. He had been referred by the optometrist and recommended for laser. After a discussion of the risk and benefit, he proceeded with treatment to good, uncorrected vision. Taken as a cohort, the visual results achieved were similar between Allegretto Wavelight and Schwind Amaris platforms. An average gain in best spectacle corrected visual acuity of 2 Snellen lines was achieved. But the unique advantage that PRK-based techniques offer within keratoconus algorithms is the ability to improve uncorrected vision in patients with high prescription or intolerance to lenses. 80% of patients treated are at the functional level of 6/12 uncorrected at 12 months follow-up. Only one patient was unable to achieve 6/12 best spectacle corrected visual acuity due to fixed haze. Despite significant topographic regularisation, fixed haze continues to limit his vision at 12 months. Based on our experience, haze is not uncommon and may appear up to 6 months after treatment, always improves but may not resolve. We advocate the use of mitomycin post-procedure as a result, despite the presumed depopulation of keratocytes that cross-linking produces. Our evolving impression of this treatment is that it is a potentially powerful component of keratoconus management algorithms. We would recommend it for contact lens intolerant Krumach stage 2 or early 3 cones. It is unsuitable for late stage 3 or stage 4. The ideal patient is asymmetric with moderate refraction and tissue of greater than 450 micrometers in thickness. Patience is required for final visual results, and haze can appear even months after treatment. The treatment only regularises the front surface and cannot eliminate aberrations from the posterior cornea. The treatment removes tissue from corneas that are already thin and represents an irreversible step. Through more communication, we expect consensus to build around the best methods and applications of this intervention. Incorporating this technique, our goals in treating keratoconus are, in order of importance, stabilisation of progression, improvement of corneal shape to improve best corrected vision, and finally, if pachymetry is sufficient, applying a refractive correction. We would finally add that with FDA approval of cross-linking and topography-guided techniques under consideration, more options may soon be available to keratoconus patients within the US trying to get out of the grey zone.